Hello, everyone. Welcome to the Preemie Chats. Thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their knowledge and experience. Also on our website, canadianpreemies.org, parents will find all kinds of resources and support. And today we're going to talk about the brain. Brain injury is not a death sentence. How neuroplasticity can heal the young brain. We often look at neonatal brain injury as devastating and detrimental bad news. In this presentation, Dr. Mohammed will explore some neuroplasticity interventions to mitigate brain injury through stories of children who had brain injury as babies. We will learn the value of social fabric, traditional reading, physical activity, and more. And I have here joining me live from Calgary, Dr. Mohammed, who is a staff neonatologist at Alberta Health Services in Calgary and a clinical professor of pediatrics at the University of Calgary. Dr. Mohammed established the neonatal critical care program in Calgary in collaboration with pediatric neurology. He's a founding member of the sonographic clinical assessment of the newborn scan program. His main areas of interest are innovation in education and quality improvement. He's a founding member of the Newborn Brain Society, chair of the Society Educational Committee, and member of board of directors. His quality improvement work led to significant reduction in mortality and brain injury in extremely premature infants and term infants who suffer from asphyxia and seizure. Dr. Mohammed received the Canadian Pediatric Society Emerging Leader in Neonatology Award in 2020. Dr. Mohammed, thank you so much for joining me here today. What a pleasure to have you here and really share this information with our parents and healthcare professionals. So thank you.
Thank you, Fabiana, for the kind introduction and for giving me the opportunity to present. Today's talk will be a bit different from usual academic ones. I will present a mixture of stories, studies, books, and anecdotes to drive points home. These are lessons I have learned from babies and their families. I want you to watch this clip from Sesame Street and remember the term food snuggies. It will become relevant and an anchor point later in the talk.
Sesame Street News takes you once more to the far-off island laboratory of Dr. Nobel Price, the great inventor, for news of his latest amazing discovery.
Hi there, this is Kermit the Frog speaking to you from the far-off island laboratory of Dr. Nobel Price, who's about to yet again show us his latest invention. Dr. Price, are you okay?
Yes, quite good.
And what is the latest invention that you have for us today?
Oh, today I have foot snuggies.
Foot snuggies are under that cover right there, yes?
Yes.
And what do they do?
Well, foot snuggies keep your feet from getting your shoes dirty.
Yeah.
And they keep your shoes from getting your feet dirty. And they keep your feet warm and snug all at the same time.
That's wonderful, and I understand that you've been working on this invention for 5 long years.
Yes.
That must take a lot of courage, Dr. Price.
Well, I'll admit I got cold feet for a while.
Yeah.
But I did not give up. Now I am ready to show the world my foot snuggies.
Oh, good. Well, I just can't wait to...
No peeking.
Oh, no peeking. Sorry about that.
I caught you.
No,
All right.
Sorry.
Ready, mankind.
Mankind is ready.
Here we have foot snuggies.
They're very pretty, yeah.
Yes, I knitted them myself.
Yes, but Dr. Price, these are not foot snuggies. These are called socks. They're socks. They're socks.
You've seen them before?
Of course I've seen them before. Everybody has seen socks.
Where?
Well, you see them on feet. Everybody's feet are wearing socks. You out there, are you wearing socks? Would you like to show the good doctor your socks? Take a look. See all those socks out there?
Yeah. You mean, look at that.
Yep.
They hug the ankle and the foot just like my foot snuggies.
Just like your socks do. Those are socks. I hope you're not too unhappy, Dr. Price.
Me?
So I don't have any financial conflict to disclose. However, I want to state that although I will present some severe brain injury cases with unusual outcome, it's in no way an attempt to paint an unrealistic picture or trivialize the hardship, stress, and suffering many parents of children with special needs are going through. This is also in no way devalue the neonatal follow-up programs, which are very important for parents and children in identifying problems early to involve them in wonderful and effective early intervention programs. As a neonatology fellow, I was trained to memorize outcomes based on risk factors and gestational age, birth weight, etc. We used to carry those laminated outcome cards to use them as a guide when counseling families expecting extreme premature deliveries. The more I learned about brain injury, the more I realized how irrelevant those numbers are when using them as fortune tellers. Numbers are important to help us, the medical team, to test interventions, study risk factors, and monitor care quality, but they fail to tell stories. Each baby is a person and cannot be abstracted or dissolved into the vortex of categories and labels. Numbers implies trends when stories acknowledge the chaos. We as a society came long way in accepting the norms of people who are far from the neurotypical tree, from euthanizing them to keep the strong genes and calling them mentally retarded, all the way to accepting them and call them people with special needs. However, we have a long way to go until we merge their norms to ours and stop giving mothers with special needs kids that judgmental look when their children express excitement or frustration in a way that makes us uncomfortable. The interventions that I will be presenting today are very effective and powerful, and yet cheap and available for everyone. People may give them fancy words and acronyms. Don't get intimidated. They are food snuggies, and we all have them and can use them. As strange as it may sound, one of the most important factors in improving outcome is uncertainty, as it opens the door for opportunity and prevents us from getting trapped in the label-locked minds, where we label our children by a disease and we get locked every time our child faces a challenge. Instead of pushing through, we find our comfort escape through the label. It's his or her disease. We can't do anything about it. Uncertainty also makes room for hope. Hope is another stepping stone in improving the outcome. It's the finishing line and the light at the end of the tunnel that keeps us fighting. Finally, all these are tools that empower dedicated parents who are master chefs in creating the miracle recipe, the miracle of brain plasticity, a brain that can heal itself. I wanted to mention a couple of organizations here. One is the Premature Babies Foundation, the Canadian Premature Baby Foundation, with Fabiana being the president of it, and the other is the Hope for HIE, with Betsy Pylon being the founder and the president of the organization. Both organizations are established by mothers with boys who have special needs, and they dedicated their lives into this organization and to improve the outcomes and take care of these babies and their families. When I was doing my neonatal neurology training with Dr. Miller in Vancouver, I remember him saying that when they put parental education level in the regression analysis looking at long-term outcome, brain injury become less significant in predicting the long-term outcome. It took them years to publish these findings, as it was hard to convince journals that this is the case. They showed that observed and predicted cognitive score in preterm children born to mothers with postgraduate education did not differ in those with and without brain injury. In another word, the association of brain injury with poorer cognition was attenuated in children born to mother with high education level, suggesting opportunities to promote optimum outcomes. This is remarkable. If we establish the three pillars, uncertainty/opportunity, hope, and dedicated parents, I would argue that available resources and where you live become less important, as each culture and society has its strengths and shortcomings. This is a documentary I watched on Netflix talking about stories of the children's journey to their schools from different countries. And one of them was this child with cerebral palsy in India. And as they were showing and talking about his day-to-day life, I was observing every single intervention that we pay money to do in babies and children with cerebral palsy. He was getting involved in the society and interacting with his friend through normal school without them being bullying or mocking or judging him. He was laughing and playing, and when he came home, his mom was massaging him after covering his body with oil. So all these are available and they were integrated in the social fabric. The third point I wanted to make is, although I will talk today about babies with brain injury, our focus as a healthcare team should remain on prevention, as an ounce of prevention is more than worth a pound of cure. We are becoming more aware and interested more in preventing brain injury through neuroprotection packages. In Calgary, we developed one for infants suffered from perinatal asphyxia following the principles of hibernation, where we allow the brain to sleep while the storm of inflammation and toxin passes through. Our catchphrase is, "Don't poke me, I am hibernating," and you don't want to poke a sleeping bear. We drew the HIE care roadmap and identified windows for interventions to prevent acute brain injury, then built our neuroprotection bundles based on that. The impact of the implementation of such bundle on moderate to severe HIE was remarkable. We showed a significant reduction in the rate of brain injury on MRI. We did interrupted time series analysis and regression analysis, and we did the analysis with and without washout period, and the impact remained. We showed that the introduction of continuous video EEG decreased the use of anti-seizure medication and improved the accuracy of the seizure diagnosis. We also reported our experience in training NICU nurses in both outborn and perinatal center and showed significant reduction in the time to EEG initiation and the hospital length of stay. And also we established our outreach program and we showed a similar impact on HIE infants. And this was also observed compared to other centers in the country. We implemented similar principles in infant born extremely premature. We developed and implemented a neuroprotection bundle approach. This is a national initiative called Drive IVH to Zero. This is my license plate reading Drive IVH to Zero, so I can literally feel the drive. The implementation of our neuroprotection package decreased the incidence of acute brain injury after adjusting for confounding factors and performing interrupted time series analysis. The Drive IVH to Zero also decreased the rate of severe neurodevelopmental injury, impairment, and death or severe neurodevelopmental impairment. This is a funnel plot showing the incidence of severe brain injury across Canada, and we used to be in the middle of the pack, and then after the implementation of the bundle, we were one of the lowest center in the country. We kept this place for 3 years. Now that is all good and well, but despite our best intention and effort, brain injury may still occur. I will present to you 4 cases of babies with severe brain injury. Their families generously consented to share their details, including names and pictures. For that, I'm very grateful. Case 1 was at 23 plus 6 days at birth. Mom received 1 dose of steroids. The baby was born at our level 3 center vaginally, was intubated at delivery room. The core pH was low, 7.19. The admission temperature was borderline, 36.5. The baby had central lines. The baby developed RDS, required surfactant, failed extubation, had CO2 fluctuation, which is a risk factor for brain injury, and mixed metabolic and respiratory acidosis. This is a head ultrasound, and I will walk you through this. The right side of the screen is the left side of the baby. These are the ventricles. This bright structure are the choroid plexus, which generates the CSF. And you can see there's a bright area here that is not on the other side. This is hemorrhage. It's grade 4 IVH because it's inside the parenchyma of the brain. And later on, this area gets chewed out and the brain tissue is lost. Here you see a CSF and it's connected to the ventricle. We call it porencephalic system. So when we were counseling this mom, we talked to her several times about withdrawing care, redirecting care, or palliative care, because you are facing a 23-weeker with grade 4 IVH and still ventilated. The risk of severe neurodevelopmental impairment is huge and very high. So, but this mom was incomplete. She refused to withdraw care and she wanted to keep going. We often said that she's not there yet when we were handing over the case after switching our service. The second case was a 25-weeker twin B. Birth weight was 500 grams, borderline IGR. Mom also received 1 dose of steroids. Baby was ventilated, had large PDA, was MPO and on antibiotics. And again, the head ultrasound showed on the right side, there is this big lump, which was called as grade 4 IVH. And similarly, we approached this family and we offered the redirection of care because we are facing 25-weeker IUGR, twin, ventilated with large PDA and grade 4 IVH. And similarly, this family refused and wanted to keep going. The third case is a term female born at home, required CPR by EMS, then brought to the hospital, was cooled for 72 hours. There were no seizures initially, and baby was hemodynamically stable. This is the MRI. On the left side is the ADC map, which showing the acute injury, and on the right side is the day 10 T1 weighted image, which shows the permanent injury. And the areas, the dark areas here in the deep gray matters, is where the injury is. And same area shows brightness on the T1 weighted image, and that's the permanent injury. When I counseled this mom, I talked to her all about the brain plasticity and putting the baby in interactive, loving environment, and that she might bypass the injury. And this baby ended up having cerebral palsy. The fourth and the last case was a 38 weeks term baby outborn because of fetal heart rate deceleration. And the Apgar score was 1, 1, 4, and 5. The core pH was 6.88. The baby has severe hypotension, required normal saline boluses, O negative blood, inotropes, was ventilated for 6 days with severe hypocapnia. The lowest was 23 and had hypoglycemia. Her EEG was initially, she had like burst suppression and then 28 electrographic figures. So she had all risk factors for a brain injury. And this is her MRI showing these bright areas here, 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 all over the brain. There were injuries. And this was reported as total asphyxia or global asphyxia. When the person who counseled the family told them that the chances of your daughter having a neurological impairment is 100%. And of course, this family was the one. How can we mitigate and overcome these injuries? It turned out that the effective interventions are cheap and available for everyone. They are food snuggies. To make it easier to remember, categorize the interventions based on our five senses. But first, we need to make a paradigm shift and change our approach from focusing on what the child cannot do or disability to what they are good at or the ability. And this is a famous book I think many of us have read and know about is by Dr. Karen Pape. She was a neonatologist and she established a neonatal follow-up clinic in Toronto. She's talking about this paradigm shift and how we need to focus on the strengths, not the weaknesses. And this is the story of the boy she faced in her clinic when she was asking him to walk. He would walk the typical cerebral palsy stiff walk, but when she asked him to run, he would run perfectly. In fact, he was participating in competitive soccer games. We also need to move away from certainty when it comes to prediction. In another word, your DNA is not your destiny. We know now with the explosion of the epigenetic science that interaction with environment or nurture can lock or unlock certain location in your genes or the nature. It is a constant, dynamic, and complex process. Let's start with hearing. We are very aware in intensive care units of the negative impact of noise and loud sounds. We have invested in audiometers with traffic lights and implemented many QI initiatives to decrease the noise level in the NICU. For example, moving handover away from the bedside, shushing the team when they are loud, discouraging laughter, etc. We even designed and built the 5-star single rooms in ICUs and thought this will be the magic bullet. No more noise, no more stress. But not so fast. Dr. Shilhas and her group showed that although there was no difference in overall noise exposure between the single room and open bay in ICUs, there were significant more periods of silence in single room in ICU. See this area, silence here, then a little bit of noise, silence, noise, silence, compared to the open bay where there is always something there and lots of noise. And then Dr. Terry Ender and her group showed that single room infants' brain were less active in the language area and had worse speech outcome at 10 years compared to open bay cared infants. This is the area of activity for the language. You can see in the normal term controls, this is how it should be activated, the color of redness. In the private rooms, it was very faint. And I would argue that in the open bay, there was too much redness here. It was too hot. So what should we do? Not too hot, not too cold. We want to get it just right. It looks like a hybrid model design is the way to go. For us at our single rooms in ICU at Alberta Children's Hospital, when parents are not present, we open the sliding doors for babies to hear us talking about them. These are nurturing and positive interaction moments. Which way, what style of reading? This was a brilliant study where they put 3-year-old children into functional MRIs and they read the same story to them in 3 ways. One, as an audio, they were just recorded their voice reading the book and then they played for them. The second was animation as a cartoon. And the third was a traditional way where somebody is reading the book while showing the pictures. And it turned out that the traditional way lit the brain just the right amount. And the audiobook was too cold. Only minimum places of the brain were activated. And the animation, on the other hand, was too much. There was too much activation in the brain, and that confused the brain. So in our unit, it is a usual habit for nurses, volunteers, and parents to read to babies in the NICU.
Richard Rabbit loves riding his red tricycle. What else can you see that is red?
This is a CDH baby
The
that
red
we had in the
feather,
unit, and our nurse
here,
reading to her
the red
book
tricycle,
and interacting with.
red pajamas, a red backpack. And what can you see in the star? Richard
Music therapy also not only effectively improve infants' heart rate, stable respiratory rate, and attenuate stress level, but also exert positive impact on oral feeding volume. In addition, music therapy also plays a role in reducing maternal anxiety. We have a child life service here at Alberta Children's Hospital, and this is our wonderful musician, Sarah. She comes to the NICU and play music for babies. One word of caution regarding music, I would discourage the use of repetitive or white noise machines. The brain gets used to it quickly and become annoyed by it. In our unit, we either have one of our amazing child life playing music, or if there's nobody there, we play a list from a YouTube for them. So here is that same CDH baby Chrissy with Sarah playing music and interacting with.
Just remember what your old pal said. Hey, you got a friend in me. Oh, you're such a good looker, hey? Do, 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 do. Do, 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 do.
What about tactile stimuli and physiotherapy? There is evidence that rubbing and massaging stimulates the brain and release growth factors. No wonder our kids love that. There are many studies now showing many benefits of kangaroo care. The most recent study was the one published in the New England Journal of Medicine. This trial had to be stopped because the intervention reduced mortality so efficiently that it wasn't ethical to continue the trial anymore. The mother is the best incubator when the baby is in utero or even out after birth. Given the strong evidence, we started allowing mothers to hold their babies during therapeutic hypothermia. This was the first mother we allowed. She burst into tears when I told her, "You can hold your baby." She held her baby for a long, long time without protection, and her arms were almost burned from the cooling blanket. Since then, we are putting a shield to protect mother's skin. Dr. Craig and her group in Maine showed the feasibility and safety of such practice. What about tests? I wanted to mention one benefit of mother's own milk here. There are many benefits that requires more than one talk to cover. It turned out that fresh mother's own milk contains stem cells. And stem cells can travel to the brain and transform to all kinds of neurons. This is one study showing that injecting mother's own milk intranasally decreased the size of brain injury sequelae in preterm extreme premature infant. Based on this evidence and others, we started feeding our HIE infants trophic amount of mother's own milk during cooling. Related to the topic of stem cells is the delayed cord clamping. Although this is a preventative measures, I wanted to mention it here because it belongs to the family of foot snuggies. When a baby breathes, the pulmonary vasculature bed opens, and if the cord is connected, it will take blood from the cord and placenta because they have low pressure. If the cord is cut immediately, on the other hand, then it will steal blood from other organs through PDA, including the brain. This is a fascinating the video with a primate giving birth and then performing all NRP initial step while the cord is intact and it's not cut. So I wanted to show you the video.
Here it comes. Here it comes. This is it. That's the head. That's it. It's out. It's out. That's it. She's starting to remove the amniotic sac. Whoa, there we go. Yes, it's...
And doing the suctioning.
Wow, she's just cleared the baby's airways. He's reacting to his daughter's birth. First sounds. This is amazing. It's incredible.
Look at the satisfaction and the happiness on both of their faces.
Here it comes.
Finally, what about the strongest sense, smell? I lived in a house where we raised cattle and all kinds of domestic animals. When a cow delivers a stillbirth, and in order to keep its milk going, they would skin the dead calf and create a stuffy so the mom will smell her offspring and produce milk, and it works. Babies also do recognize odors like peppermint clip here, where Dr. Sarnath is testing the olfactory.
Reacting. Well, she's yawning. So that's not quite the response I was hoping for, but there. See that mouthing, the lip smacking with the peppermint? So I would consider that to be a positive reaction.
Babies do certainly recognize their mom's scent. This study assessed the responsiveness of newborn breast and bottle-fed infants to presentation of maternal odor. The results indicated that if the babies were crying, they become calm when they presented to their own mother's scent and others' mother's scent. And also, if the baby was awake, they only calmed down when they smelled their own mom's scent and not others' moms. In our perinatal center, nurses started a project called Love Bug, where the nurse will give a clean piece of fabric to mothers that can't visit an ICU due to C-section. She will rub it on her chest, and then the nurse will put it inside the incubator for the baby to smell. Putting intervention that target all our 5 senses is the essence of family integrated care or FICE care approach. FICE care is the standard of care approach due its proven benefits with no side effects or downsides. All these neuroplasticity interventions we are implementing in a family integrated care model are put together in this beautiful piece of art by our NNCC nursing leads, Jan Lintz and Norma Oliver. And this book on the right is a book written by a professor in psychiatry talking about some stories he faced in his clinic and the impact of social fabric and how strong social and family dynamics can buffer parental disability and save a child from a disability. Many of the neuroplasticity interventions are common sense and don't always require an RCT like this picture I took from our elevator at ACH. You don't need an RCT to know that people are more anxious to reach their appointments, meetings they're getting out because the closing button is worn out more than the opening button. So you just need a good eye and attention. What happened to those 4 cases with severe brain injury? And I intentionally called them cases and didn't give them names. And I want you to compare your feeling toward them before and now when I give them names and you see them as people and person. So the 25-weeker twin B was Python, her sister is Scarlett. Their parents, they put them in all kind of interactive, loving environment, from playing, challenging, goofing around, camping, taking risks. And here is the picture them playing with throwing rocks in the river or creek. You cannot tell which one of them had the brain injury and which one had the normal head of it. They are both interacting together. And here are they now. They are very normal grown-up young girls. They go to normal school, they hear, they see, they walk, they talk. Emerson was the girl who was born at home and had acute profound asphyxia and delivered cerebral palsy. Despite her having cerebral palsy, she's a life force and she has no fears and she pushes through all boundaries. She was the poster child for life without limits. And her mom, Tara, dedicated her life for the cause. She helped us in getting many grants to look and prevent brain injury in HIE and premature babies. And finally, after all these efforts, she finally walked. You can see her here walking.
In 10 minutes.
You see the joy and the dance that she's making at the end of that. And Kagan was the one that when the physician counseled the family, they told mom that your baby will have some kind of disability, 100%. There's no way around it. She is a character, and she, in fact, we discharged her early from our neonatal follow-up clinic because she was ahead of her milestone. She runs, she talks, she reads, she's super intelligent. And here's her exercising in her garage.
Whoa, Chief.
That's a good one.
And then this side.
Good job.
And then this side too.
Okay.
This side would be easier. No.
And the last one I wanted to leave you with is Harper. Harper's was the 23-week care with grade 4 IVH and 1 dose of steroids, where we repeatedly counseled the family and offered the redirection of care. And we thought that mom wasn't there and she didn't get it, that she couldn't see the impact and the risk that her daughter will have. And here's, I want you to see her and how well she's doing.
Yeah. You are my sunshine, my only sunshine. You make me happy. You'll never know, dear, how much I love you. Please don't take my sunshine away.
Thank you.
Now can
You are my sunshine, my only sunshine. You make me happy when skies are gray. You'll never know, dear, how much I love you. Please don't take my sunshine away. The other night, dear, as I lay sleeping, I dreamed I held you in my arms. When I awoke, dear, I was mistaken. So I hung my head and cried. You are my sunshine, my only sunshine. You make me happy when skies are gray. You'll never know, dear, how much I love you. Please don't take my sunshine away.
I wanted to thank my colleagues, institution, families, and babies. I could never be able to do and present this without them. And this is my own sunshine. Thank you very much. I'll be happy to take questions.
Dr. Mohammed, thank you so much for your presentation and for your approach to brain injury. It's always very refreshing to see clinicians that don't see our kids as deficits when they do have a brain injury or a disability. So thank you for that. So my first question to you is, you talk about these very simple interventions. There are no cost to most of them. And very well documented, very well studied with research. Why they are not all widely implemented in an ICUs?
Oh, that's a good question. I will answer it by another story. We had a neurosurgeon who visited us from Harvard and gave us a talk about hydrocephalus management in children. And he said he left his job and went on a mission to Africa to manage hydrocephalus in those villages. And while he was trying to treat and manage those hydrocephalus cases, he found that it's not feasible to treat it with shunt, because you put these shunts, they go away, they don't have good system of follow-up, they come back with infection and like big heads, it just doesn't work. And he was reading back in the history, he found a way of treating those hydrocephalus by making a hole in the third ventricle. So the brain itself will recycle the CSF without needing for the shunt. So he was able to come back and convince the shunt companies to fund an RCT, comparing the shunts versus his approach. He cauterized the choroid plexuses and make a fenestration in the third ventricle. And to his surprise, his approach was better than the shunt approach. So he went back to his Harvard institution and he presented his findings to his institution. Said, "Look, this is better and this is cheaper." And he said, "These are his word." I'm quoting. He said, "I got a pad on the bag and said, well, this is good for those places. We have our like fancy stuff that we want to use. We don't want to use this cheap interventions." I don't know, to be honest with you. Sometimes when things are available and free, they lose their values. Somehow we need to make them like the Gucci in order to buy them. You don't want a Walmart version of stuff. That would be my suspect.
Okay, Dr. Mohammed, you can stop sharing your screen because I'm not sure you can see us.
Stop sharing.
Yeah,
I can see
now
you.
you can see the screen here. So, you talk about FICARE, and you know we are big advocates for FICARE, family integrated care, to have parents involved in the care of their babies, which automatically all those 5 cents will be present when the parents are present in an ICU. And you've seen for the last year and a half the restrictions in an ICUs across Canada and across an ICUs around the world. The parents have time limits to be in an ICU with the baby, one parent at a time, and all these restrictions that keep going on and on and on as the pandemic progresses and go to different waves. So what do you've seen for the last year and a half, and what do you think the implications will be for those babies on the long term when the parents are not there?
Oh, the implication, I think, will be huge to all of us. We see it in our own children and our own kids at home. It will be devastating, and anything we can do to decrease that, the impact will be helpful, even if it's small. If the parents are not there, if we can go and talk with the babies, and the way in our own unit we have volunteers, we have nurses, they are really amazing. They go and read to babies when they have free time. They play music. If we can, some units I know they have like this Zoom with the parents. They have this virtual NICU with them. Wherever we can do, it won't be as perfect as having the parents with the smell, with the holding, with the tactile stimulation and that face-to-face interaction. But we can do those small things to at least decrease the impact. And I actually think we need to move the family integrated care one step up and make it family directed care. One of the changes in my practice I have made is like when I come on service, I meet with the families and ask them, now you have been here, especially for chronic babies, you have been here for 2-3 months. What will be your goal at the end of week? What do you want to see changed or improved in your baby's care? And they usually have like really nice ideas. Say like, I want to move my baby's respiratory from 6 liters to 5 liters by the end of it. I want to progress his or her feeding from this to that, etc. And that way, I found the parents become engaged a bit more, and then the trust between the team and the families improve.
Absolutely, and also empower the parents to continue the journey after the NICU, because if you look at our lives, we spend weeks or months in the NICU, but then you have a whole life ahead with the child, that we have to feel empowered and absolutely knowledgeable to take care of the child at home. I have somebody from Zimbabwe saying hi. Francis, thank you for joining us. I also have a comment here from Sarah. Sarah is our regular parent here with baby Logan from Barry. It's absolutely amazing. So beautiful to see such happy endings. I just want to add a comment here because we always, I'm a big advocate for kids with disabilities because my own son, he was a preemie, has quadriplegic cerebral palsy. And we obviously always want to see our kids running. And despite all these diagnoses that we have, we really thrive to get the best for their children to walk or to do this. But the reality is some won't. And that doesn't make their lives less worth it. And we still love them. And for me, having my son with quad CP, it is a happy ending because I do have him. And I think this is what we need to shift in our society. And I think this is what Dr. Karen Pape talks so much about in her book, how we shift, as you mentioned, the paradigm from seeing the problem, but look at the opportunities. And you have this beautiful quote that uncertainty opens door to opportunities. And I think that is what it is, right? If your child is going to have a disability, how can you see these moments of uncertainty, but give them every opportunity possible? And I think, and I want to ask you, because you have a different view from many other clinicians I've been talking to for the last 9 years that I've been in this road. How do we change this paradigm within your community of neonatologists, neurologists, people who counsel families?
I think I first of all agree with you 100%, Fabiana. And you having like two spectrums, the neurotypical and disabled child, you can tell that there's no difference in the amount of love they are giving. And I always say love has no disability. You can't have disabled the love from and correlated with the brain injury. And success is very relative. Like in my house, if my kids put their dishes in the dishwasher, that's a big success for me. And that might be like something no-brainer for in another family. So that's why I find numbers are disservice to the family. I stopped carrying those cards. And even if the family asked me for numbers, I said, I'm not giving you a number because it's not accurate. You are different. You are like your son, your daughter, your family, your environment is so complex. You cannot lump them into a category. It's just not right. I think going back to your question, I think we are changing. And I think by talking more and more and learning from our own experience, change is coming. It might be slow at the beginning and then it will just take off. And I think the pendulum will swing to the other side and then we'll need to bring it back and be balanced. Just like the story that happens with the child that I was counseling, because I'm usually positive when I talk with the families. And then that mom, Tara, came back to me and she said, like, you should have told me like this, my kid may have cerebral palsy, because I was shocked when they told me that. And she was right. Like now when I approach the families, I do still keep the hope, the positivity, the uncertainty, but I do mention the terms. I say, like, you will hear the term of cerebral palsy, you will hear the term of speech delay. That still may happen, but we don't know. And the fact that we don't know is a good thing. It's not a bad thing.
I agree with you. But I think also I always look at the other side, right? I always look at the doctor's perspective, because it's also very difficult for you to predict. And some families want more information, some families want no information. And for me, the fact that my son did not have IVH brain was completely out of my radar. The whole focus on Gabriel was on his breathing. So for me, when he was delayed in the first year of life, it came as a little bit of a surprise, because as much as I was educated at the hospital that I was, there was not active conversation around cerebral palsy because it was out of our radar. But I think it is important for families to be aware of the possibilities, but also to the fact that they feel if they have a diagnosis down the road, they are not alone. There are other parents who have walked that path. Because when I heard that my son had cerebral palsy, I'm the only an ICU parent that has a child with cerebral palsy, because I had never met one before. So for me, like knowing that other families have walked that path, it is very reassuring that I can make it to the other side as well. And we are going to still be having a family, having a life, and do things in a different way, but you can still do things that we planned. And I think that is a message that we always have to give to parents, that no matter what is your child, and you love that child unconditionally. It's not always easy. There's a lot of hardships, but that's the reality. I want to bring another comment here from Michelle Peltier. She's from Vancouver. Michelle, thank you for joining us. She said she loved family-directed care. Loved it. I do too. And she has one more comment. Parents are the most consistent care providers for their children in both short and long term. And I also want to give a shout out to Lori Roma. She's joining us from Kenora. And her baby now is, I think, over a year old, and Lonnie and Biara. So they all loved your comments, your presentation. So Dr. Mohammed, one final message for our families and for healthcare professionals watching us here today.
I would say don't ever lose hope, and don't let anybody take your sunshine away, and embrace uncertainty. That's what I would say.
Absolutely. Thank you so much, Dr. Mohammed, for joining us here today. It's such a pleasure talking to you. And I hope you come back to our live chats, because I do want to talk to you about your work with quality improvement in Canada. But thank you so much for today.
Thank you for having me. I really enjoy it and appreciate it. Have a nice day.
And for all of you watching us live from home or the hospital, thank you so much for joining us here. This video is available on our YouTube channel, or also on our website. And all videos from our live sessions are available on our website, which is right here. Let me share the CanadianPremies.org. I want to thank our sponsors, AstraZeneca and Water Wipes, for their ongoing support to our education sessions. And we are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I will see you again next Friday at 1 p.m. Eastern Time. Stay well, everyone. Bye for now.